ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. If you're approaching 65 or past that significant birthday, you know the ritual really well. The mailers stack up, William Shatner and Joe Namath beam from the TV. The radio promises free gym memberships if you call in the next 10 minutes. That's no accident. This fall's Medicare Open Enrollment window runs October 15th through December 7th. The brief season where every Medicare beneficiary can compare, switch, or drop coverage for the year ahead. It's the Super Bowl of insurance marketing, and you're the MVP. Here's the scale of what's at stake. More than 34 million people, about 54% of those on Parts A and B, are now in Medicare Advantage plans. That share has nearly tripled since 2007, and it's still climbing. Think about that. Most new enrollees are choosing private plans that promise coordinated care, simpler bills, and sweeteners like dental and vision benefits. And those ads you're seeing, they work because they sell the sizzle. 92% highlight extras like dental, vision, or hearing coverage. 2/3 of MA plans charge no premium beyond Part B, and almost all offer those extras in some form. The message is simple. More benefits, less money, act now. The reality is more complicated once you need real care. Consider what rarely makes the commercials. Nearly 50 million prior authorization requests ran through MA plans last year. More than 3.2 million were denied. Only about 12% of those denials were actually appealed, and when they were appealed, 8 in 10 were overturned. If that sounds upside down, you're hearing what doctors and patients feel like at the bedside. Federal watchdogs have also found denials of care that actually met Medicare coverage rules, which tells you the friction is not just a paperwork headache, but a barrier at the bedside. Wall Street Journal reporting from earlier this year found some Medicare Advantage insurers pumped up risk scores and leaned on questionable home health visits, driving billions in extra payments that taxpayers ultimately cover. The Justice Department is suing major insurers and brokerages over alleged kickbacks to steer seniors into certain plans and has secured settlements over false diagnosis coding, including a more than $62 million deal with Soul Medical Group. Courts are a battleground. United Health recently won a key special master ruling in a long-running overpayment case. So enforcement is active, but fiercely contested. This proves the golden rule. The one with the gold makes the rules. That friction shows up in the exam room and at the front desk. Your long-time medication might fall off the formulary. Your specialist could be out of network mid-year. Your surgery gets delayed while offices chase approvals. Yes, you can make a one-time switch in the first quarter of the year if you pick the wrong plan, but leaving MA doesn't guarantee you a Medigap policy. In many states, insurers can still underwrite and say no. The stakes are high before you ever sign. Which brings me to today's guest, someone who sees this maze up close. Jaime Fiore is a fierce patient advocate and the practice administrator at Rheumatology Associates in Stuart, Florida. She consults with manufacturers, is a certified medical practice manager, and, believe it or not, is a prior authorization certified specialist. I didn't even know that was a thing. Jaime and I have walked the halls of our state legislature together. She knows how policy lands in real clinics with real patients. So, As the ad blitz ramps up, let's ask what matters. If MA must cover what Medicare covers, why do so many people hit prior authorization walls? When almost every plan pitches free extras, what do those benefits actually buy when you're sick? And when millions of denials stack up each year, who is accountable? The insurer, the regulators, or the rest of us for believing the sales pitch? Jaime Fiore, welcome to Working Healthcare.
Thank you for having me.
I am so excited to have you here because you and I have known each other for a very long time.
Very long.
For those who don't know you, they're not in the rheumatology world, because you and I actually were part of the planning committee for the Florida Society of Rheumatology together, and that's where we first connected.
Yes, many years ago.
Many years. We won't say how many.
We won't say.
Okay. So I really want to know, what do you do day to day at Rheumatology Associates?
So I am the practice administrator. Because we are a smaller office, I am tasked with handling everything from plunging the toilets to hiring and firing, prior authorizations, filling in when someone's out, answering the telephone, handling patients that have a less than a happy experience with their insurance company and are mad at us for some reason. Pretty much everything you can imagine falls under my umbrella.
Pretty much everything. And it's funny you say plunging toilets, because people will say, that's not my job. And I'm like, well, yeah, who else is going to do it? I mean, we can hire a plumber, but we need to teach our lady employees not to flush feminine hygiene products down the toilet. When you hear Medicare Advantage, what's your gut reaction?
Yikes.
Why?
Because I have seen it in play for patients that have chronic illnesses and how they are told or assume that it covers them, it covers their medication that they're on, and it's a better plan than regular Medicare. What they're actually hit with is roadblock after denial, and the cost of actually receiving that medication that they need to be on to stay healthy is astronomical in most cases when you're looking at a biologic medication. They're infused in the office generally. In rheumatology, we do a lot of biologic medications. And, the 20% with Medicare that they don't cover, you can usually get a supplemental plan for that. Medicare Advantage, you don't always have that option. You don't have that option.
So why do patients who are healthy think, but I'm healthy, when it really gets tough, I'll figure it out? What's the detriment?
So the detriment is trying to get back into the regular Medicare system. It's difficult. It's very difficult. Oftentimes you have to go through underwriting. And if you have any chronic condition from diabetes to cancer to rheumatoid arthritis, psoriatic arthritis, you have to go through that underwriting process. So you may not always be able to get that supplemental plan.
So my oldest son's girlfriend's father, if anybody wants to try to follow that, but he said, I can't keep listening to your podcast, Meredith, and be on Medicare Disadvantage. So he actually tried to switch last year and he was denied. He didn't even get an offer for something that was unaffordable. He was flat out denied. And so I just saw him at Rosh Hashanah services this past year and I said, so what are you going to do? Are you switching to Medicare or you're sticking with Medicare Disadvantage? He's like, I don't know if I'll qualify. He goes, I think I will. I spoke to my broker. I said, why were you disqualified last year? Why were you denied last year? And he said it was because he was hospitalized. And it was actually for really a non-issue type of thing. But even for like a 1-day hospitalization, insurance companies can deny you.
And we hear stories like this all the time, but it's not made public knowledge. I think there is a detriment to Medicare beneficiaries because they don't realize this. And I think this is what I'm glad you have this podcast, because that's what we want to make public. There are rules and regulations to any plan you choose, and you have to make sure you're well informed of what you're actually getting into before signing that dotted line.
What do you think is the biggest challenge for patients who choose these MA plans? What is that one thing that you come across in your clinic that you're like, I told you so. We don't want to say I told you so, but what is that one issue?
Care coordination, 100%. You cannot always see the providers that you've been seeing for 20 years. They are not in the network. They don't have the administrative ability to handle the prior authorizations required to be in network. And, you want to see the doctors that you've built a trust relationship with. That's not the case with Medicare Advantage. And in my clinic, we don't take Medicare Advantage plans. I have to turn people away all the time. And we try to educate as much as we can, but there will be that one agent that gets them to sign on the dotted line saying, this is the greatest thing since multicolored toothpaste. And ultimately, they cannot see us as their rheumatologist. And in my area, the next rheumatologist is 30 miles away. And when you're already not feeling great, that drive is difficult.
And does that rheumatologist take MA plans?
I do not know.
Well, I was just thinking.
I actually know. I don't think they do because we both know the rheumatologist.
Right, exactly. And I take very few MA plans. And it's not that I said away with MA plans. And my decision for choosing not to take these MA plans has been gradual over time. Because when we first started, I did take these MA plans, but either the insurance company like Florida Blue actually took 90% of rheumatologists off of their panel. So to find a rheumatologist in Palm Beach County, which I don't know if people are aware, you and I are in the same county. And how long did it take you to drive to the studio?
An hour and a half.
Yeah. And you and I are in the same county. Palm Beach County is actually the largest county geographically in the state of Florida, and we're a pretty darn big state. So for patients to try to get coverage is very difficult. So if they can't find a rheumatologist, where do they go?
Yeah, and you consider things like, things that could be more emergent, like cardiologist. You're having a significant heart problem. You want to be seen that week at the very least, and coordinating care. And then you need a prior authorization on top of that. It makes it very difficult. Is it going to be denied? Are they going to even allow you to see that doctor? Testing, denied all the time. Medications that are necessary, denied all the time. Even down to the prescription drugs and formularies, which I'm sure we'll get into. Mm-hmm. You really need to do your research and know what you're signing up for before you sign the dotted line.
So it's interesting. Let's get into that now about the formularies. So at the end of every month, I get a report, which actually I'm going to talk about reporting at the Rheumatology Access Network conference that you and I are both going to and flying out to tomorrow. But I am sharing these reports, and I reviewed September yesterday. And while I was reviewing it, I'm looking through there are 4 types of reports we keep. And one of the reports is non-starts.
Yeah.
And so I'm scrolling through my non-starts and comparing it to those patients who were put on medication. And there isn't one Medicare patient who was on the non-start list, and several either MA patients or those who are on traditional insurance because they're younger, like you and me, and we have to go through a formulary. So could you explain what a formulary is for those who aren't familiar?
Absolutely. So formularies, insurance companies put out a list every year, even sometimes twice a year, of what medications are actually covered or preferred with their plan. If your medication that you've been taking for years is not on that formulary or drops off that formulary, I think that's very important that we say that, because they can drop that medication mid-year, then they will not cover it. You can appeal it, you can appeal a denial, but like you say, it's very difficult to get the insurance to overturn that process.
Have you seen that patients were given a prior authorization for 6 months or an entire year, and then their formulary changes mid-year?
Mid-year, yes, absolutely. We're starting to see that, which I think it's criminal. I honestly think it's criminal. I think and a lot of our patients are very sick, and we get them on a medication and they're stable after much trial and error, and it's finally working. They feel good. They can actually function in their day-to-day life. To have the insurance company then drop that medication that we fought so hard to find something that works, it's frankly, it's disgusting to me.
So what happens? Are you actually notified from the insurance company that the formulary was changed?
Not always. No, sometimes we know after we get the denial when the patient's already got the medication.
So what happens?
So you appeal it and you don't get paid ultimately.
So who's responsible?
It depends on if it's in-office administered or if the patient's picked it up. The patient can be responsible if it's something they've picked up from the pharmacy. It can fall in their lap and they get that bill, which, is that fair?
What do you do in your clinic for patients who you received a prior authorization, the insurance was changed mid-year, you go through the process of verifying that their insurance is active, because that's typically what we do. We don't go in to check that the prior auth is still active. We see the dates of the prior auth, but we check that their insurance is still active. We infuse them once, twice, 3 times, and then it's denied. And now there's a $30,000 bill. What do you do?
Yeah, you start the appeals process right away, but I can tell you that a lot of times that is not successful because it falls back on the provider's lap. You should have known. We did the due diligence. We have the paperwork. We've been through the process, but ultimately they can do what they want and there's nobody holding them accountable.
Can you balance bill patients?
You cannot. You cannot. If the insurance denies it for lack of prior authorization, that it says provider responsibility right on the explanation of benefits.
So what are the options for practices? Because I have a lot of physicians and practice administrators like you who listen to this podcast and listen to Working Healthcare. What are the options? You're $30,000. Are you kidding me? We're working on such small margins anyway.
Really, ultimately, we're paying for the drug for the patient. We're buying their medication, and my doctor always says we don't work for free for insurance companies. We do free clinics for patients that need it, that have needs, because that's the type of people we are. But to work for an insurance company that should be, the patient's paying their premium to them, it makes it very difficult. And I've wrestled with that myself. What is our option? Do we just stop taking insurance completely? We want to help patients, but I don't know what the option is, honestly.
So it's interesting you say that because I just ran a panel discussion for the Coalition of State Rheumatology Organizations, and I was asking for feedback on LinkedIn, and I said, what is your biggest challenge with MA plans? And one rheumatologist who you and I know well, who's in a large group actually, said, I wish we didn't have to take insurance. I wish we could do a direct pay model. Is that feasible in rheumatology?
I think it's difficult because our medications are so costly, these biologic medications. And we have the large majority of our patient is the Medicare population. They're living on fixed incomes already. To have them come up with this kind of money for their medications or even to wait to be reimbursed, it's just not feasible. It's not feasible from my standpoint. So
we're 80% traditional Medicare. We do have some commercial carriers for our younger patient population, but only 3 that I can think of offhand. And we only cover one MA plan. And so 80% were traditional Medicare. What about younger people who need physicians? Where do they go?
Yeah, that's why I think they need to start thinking about this now. And they should actually look at their plan, whether it's commercial or Medicare, too, to see what's covered and what is the prior authorization process, what's on the formulary. And don't trust an agent. Remember, they're a salesperson. They get paid by the insurance companies to I don't want to say to steer you because they're not supposed to, but, there is some kind of end game there. And, talk to your physician, talk to the physician office staff, ask them, what is your biggest headache? What is the best insurance? If I signed up for this plan, will I be covered? And they will give you an honest opinion if you ask. Ask your pharmacist, these are my medications I'm on. What is the best Part D plan to choose? If you're a commercial patient, what is the best plan? When I'm talking to my agent, where can I go with what I'm taking for my illness?
And there is an out-of-pocket max right now for
Yes.
Part D plans if you have that Part D supplement. So This year it's $2,000. Next year, I think it goes down to $1,500.
I've heard multiple. I've heard 2,100. I've heard it's dropping. I don't think they've landed yet.
Okay. Well, I thought it was 1,500, but there is a cap. Unlike in past years where patients would hit a donut hole, they'd be responsible for the entire amount, and then it was 5% of the cost of the drug. And I've shared this before on the podcast. My mother-in-law, when she was provided or prescribed a drug, she does have traditional Medicare. She does have a secondary, and she has a supplemental Part D. And prior to this year, that drug would have cost her $18,000 additional.
Wow.
So it's crazy.
That is crazy.
So I'm sharing this because patients have an option to go into traditional Medicare or an MA plan. And many will say, I can't afford traditional Medicare. Now there's a guaranteed cost for you on traditional Medicare. But why are the other reasons why patients would choose a MA plan?
I think they're not considering the entire cost of care. You go into these sales agents, they promise you, oh, well, your hearing aids will be covered. The person may not even wear hearing aids, but it's a benefit. Your glasses will be covered. But if you consider a traditional Medicare plan with a supplement, you're covered 9 times out of 10 at 100%, no matter what, without a prior authorization. The actual Medicare Advantage, Disadvantage plan, however you want to say it, there's going to be a copay for every doctor's visit. There's going to be a percentage that you're going to have to pay for medication if it's covered, if you can get it prior authorized. So the actual cost of care could be 10 times the amount that you're paying for your annual premium. So consider the entire cost of care and look at your family history and your health history. You don't know what's going to happen 5 years down the road. You may be relatively healthy now. No one expects to get cancer or expects to have a heart attack or a stroke, or expects to, be diagnosed with a chronic illness. All those things need to be taken into consideration before you sign up.
And I also think that when you're looking at the whole entity of traditional Medicare versus MA plans, the biggest kickback I hear from patients is, I'm on a limited income.
Yes.
But I say, do you get your hair colored? Right? Do you get your nails done?
Do you go to brunch?
Yeah. Do you go to brunch? Do you go to happy hour? Do you go to the early bird special? Yeah. Like, is there a way to decrease what you're spending elsewhere and make that your cost of living?
Absolutely. And this is one of the single most important decisions you can make. I mean, you're talking about your life, your health, and to have a middle person denying your care so you can't get the care you want or need. It's very difficult. You need to really weigh the cost before you choose.
So what I learned, interesting, even through this podcast, and I love the podcast because I'm always talking to people, learning from experts, learning more from you and others. And one item I learned when I had interviewed an insurance agent, because I wanted an insurance agent around last year for open enrollment, is that they are not licensed to sell every insurance plan. So if you have your best friend's son who sells Medicare Advantage plans, he may only be able to sell United Healthcare plans.
Right. That is true. And they are only allowed to discuss with you when they go into your home what you have asked it for to discuss in a pre-interview,
really?
Or that you have to fill out another form. That's the new regulations. So if you don't know what's out there, your whatever's on that form is what you're discussing. So you don't have that full rounded picture that you would if you were to talk to your physician and your pharmacist and people that are actually in the daily grind of doing this. So that's why I think it's so important. Don't rely on the agent. Don't rely on your best friend. Talk to the people in the world of healthcare.
I like that because that's what we do in our practice. We will tell patients, especially our infusion patients, right, who are considering, we have a huge sign, hey, ask us if your medication is covered.
Yeah.
Right?
Absolutely.
And so we will do that. Do other practices do that?
I would hope they do. We try to educate as much as we can, but there's a very fine line. We have to be careful. We are, like agents, we aren't allowed to lead patients to a certain plan. So, we can answer their questions honestly when they ask us. So, and then I think that's a good point too, knowing the right questions to ask your physician or your doctor or your doctor's office staff. You want to find out if your medications are covered. You want to find out, does the formulary change a lot? Do I need to be worried about this? Am I going to be kicked off this medication after I start it after 2 treatments? Those are the important questions to ask.
Yeah, but I'll say you don't know what you don't know.
Right. You're correct.
And so you don't always know what to ask. So that makes it really difficult. Yeah. Is there a time when a denial really hit home for you and why you became such a fierce advocate for patients?
We had a patient that was very sick. She had something called Wegener's, and this was many years ago. There wasn't a lot of treatments for it. She'd already undergone a lung transplant. I almost get emotional talking about it because she was very young. Mm-hmm. And to have her, she had one medication that would have kept her alive, and the insurance company denied it. My physician fought fiercely, wrote letters, called, spent hours on the phone. Ultimately, the patient passed because we could not get her on the medication no matter what we did, and she could not afford it. She had not worked for years because she was so sick. And, having her come into the office and say goodbye to all of us, knowing it was the end, was so hard, so hard. And there was no reason for it. I mean, it wasn't even that costly of a drug. And I think things like that, we see patients like this, and it's hurtful because you work in the service industry because you want to help people and in the healthcare world, and you want them to get better. You want them out of the wheelchairs. You want them not crippled and to be able to tie their grandkids' shoes and to grow old, and then to have a middleman step in and just completely flat out deny care. It's hurtful.
And it happens even with patients who have been on a medication.
Yeah.
So I had Dr. Boris Bakari on the podcast, and he created a way to fight denials, especially AI denials, right? Because they're all using AI now, using AI to then appeal those denials. And he shares a story on the podcast that he's an asthmatic, and he's been on this asthma inhaler for 20 years, and he lives in LA. So when the wildfires were going on, It was a crazy situation, especially exacerbating his asthma. He went in to fill his meds, and it was denied. The inhaler was denied. He's like, I've been on this medication. Yeah, 20 years. And he's like, I'm just going to pay it because I need it. And thank God he could. But then he went in and he created an algorithm to fight this denial, and he won and got reimbursed. But that's because he created a darn AI company to fight denials. So what does the average person do?
Yeah, and I think a lot of them either don't have the knowledge or the means to fight it. And then to your point too, they don't have the financial means to pay for the medication. So if it's denied, they're like, okay, I'll just go without. And sometimes they're even too embarrassed to tell the physician's office. And we don't know that they're not taking their medication. Mm-hmm. And that's hard too, because how do we, we're wondering what's going on. They're too embarrassed to tell us they can't afford it. The insurance company's standing in the way of their care. But yet we're rated on quality, so it's this like big filthy loop that we can't fix.
Right. That's really interesting. Connecting the dots. You're right. Yeah. We're rated on cost. Yeah. We're rated on not just quality, but cost measures. And we're like, okay, the person ended up in the hospital. Why? Because the insurance denied
their medication.
And so you're like, okay.
But we appealed and did a peer-to-peer. And by the way, peer-to-peers aren't always peer-to-peer. Even when you ask for somebody of equal caliber, they will put a retired physician that hasn't practiced for years that doesn't even know.
Who's a pediatrician, by the way.
Yes. Doesn't even treat adult patients or hadn't treated adult patients with rheumatoid arthritis. And we fought for it, but they ended up in the hospital anyway because of the middleman. And
Can you give me a story when you fought a denial and it actually was successful? I want to give hope. And I want to encourage people to fight denials.
Yes.
A lot of times patients, and I have shared the statistic many times, such a small percentage are actually fought. And a lot of times patients think that the doctor prescribed the wrong medication because the insurance company denied it. So you got to connect the dots a little bit more. But if you fight a denial, Give me a story when it was
So
successful.
there's a lot of them, but I think the one that comes to mind first is a lupus patient. Yeah, she was on a medication and they denied it after I think 2 treatments, and they said, you know what? It's not our formulary anymore. And she had been through other medications, and this was the only one working for her. So we did the peer-to-peer thing, denied, denied, denied. Finally, I said, you know what? You need to make noise at the insurance company to the patient. The patient got involved, and it wasn't our office. It was the actual patient that fought and got it approved after that. And I'll real quick, I'll side note that I have a commercial insurance, my own personal medication that I've been on chronically for years. I threatened to take them all the way to the insurance commissioner, and I got a call the next day. Oh, how can we help you? Did it get resolved? Can we approve your drug for you? So sometimes it takes the patient advocating for themselves and making noise and pushing back. Honestly,
I will say 100% it takes the patient.
Yes.
I will go back to what Julie Bach said on my first ever episode. She said, I will stand shoulder to shoulder with you and fight this denial. But if you're not with me, I can't do it.
Right. Patients have to advocate for themselves. I mean, there are those patients, though, that just don't have the strength to do it. I mean, I'm thinking of our cancer patients and stuff, which it puts us in a whole nother position. We're trying to deal with all the other administrative burdens of getting prior authorizations for thousands of patients, but this one patient matters just as much as the rest of them. So, how do you spread a staff of 15 where only 2 or 3 of them do prior authorizations to your whole patient base? And they're on the phone. And you wait an hour when you call these insurance companies at minimum, and you're passed to 5 or 6 people only to be hung up on. So it's a difficult road.
When I started almost 18 years ago this month, actually, our nurse, I didn't even know what prior auth was. I was like learning this whole process and what a denial was. And as I got a little savvier, and we had outsourced our billing at the very beginning, and then we quickly took it in about 2.5 years later. But our nurses or our LPNs were the ones who are actually going through the prior auth and through the appeal process. That's what happened. Were we as successful? There weren't as many as there are now.
Right.
We have 3 full-time people dealing with prior auths and appeals and denials right now.
See, and I feel like, I started 23 years ago in my office, and it did not take as long. I like you said, I don't think there were as many denials, and I don't think they kicked them back as much. But you're right. You have to have a full-time, 3 or 4 people just to handle the volume. And the insurance company, they're just hitting a button. They're hitting a button on the computer.
It's
deny,
insane.
deny.
It's insane. So if somebody picks an MA plan, and they're listening to this after it was chosen.
Oh, no.
And they're like, oh, man, you're right. This sucks. What do I do? How do you turn in the lemon?
So you can you can disenroll in the Medicare Advantage plan. January through March actually is the Medicare Advantage, disadvantage and open enrollment period. You can also switch if your plan is not rated 5 stars, but that's to go to a different Medicare
Oh, please,
Advantage
that's a
plan.
game. They always
Yes,
rate themselves 5 stars.
Exactly.
Or get it,
But
right?
during your open enrollment period, you can definitely call 1-800-Medicare, your best friend.
That's what I say. 1-800-Medicare is your best friend. But what is the hiccup that patients will face?
The hiccup is the secondary insurance and going through underwriting if you have to get that secondary plan. It can be difficult, or like your son's future father-in-law. Did I say that right?
Perhaps, yes, perhaps. You are right.
Maybe. Sometimes they'll just flat out deny you and not let you enroll in a secondary plan, which then your cost care can go up.
Does that happen even if you make a blip at 65 and it's your first time?
It can. It can. Yeah. For sure.
That's what I think is so appalling, is that the first time you make a mistake, like you're not, it is a mistake because you can't backpedal. Yeah. You're screwed.
Yeah. and I have actually sat down with an elderly couple, friend of mine, and walked them through the Medicare enrollment process. It was difficult. And I've done this for 23 years, but I've never been on that side of it. And I'm thinking, if I didn't have medical knowledge, this would be so hard. So, there's a lot of states have SHIP programs where they go through and help you. They're supposed to be not biased, and help you enroll. I would encourage you to reach out to those plans and have somebody knowledgeable kind of tell you in layman's terms, what does it mean if I sign up for this plan versus this one? And then also your Part D plans too. Don't forget about that because your prescription drugs can be costly as well. And you want to make sure you're enrolled in a good Part D plan that covers the medications you're on.
Exactly. The medications you're on or the medications you could be on. Correct. And sharing that or speaking to the pharmacist or speaking to your practice that you go to, right? The billing team. Hopefully they'll call you back.
Exactly.
Oh, I don't know about that sometimes. I know they will in my office.
Show up in person.
Oh, I've had patients also show up because they were frustrated at the letter that their insurance company sent them. And Susan's great. She'll grab it and she'll say, could I have a copy of that, please? So at least we have like more push and fight and we can share the information with everyone. You have been involved in advocacy. Yes. You're my groupie. We're a groupie of two. You're my co-practice administrator who actually goes up to Tallahassee with me, which I'm excited about. And you were on our National Organization of Rheumatology Management board, and you're going back on the board again this year. If you had 1 minute with a lawmaker, I know, I'm putting you on the spot. 1 minute with a lawmaker, what fix would you demand first? Oh. I'm only going to make you choose one, but what fix would you demand?
Cut out the pharmacy benefit managers for sure.
Yeah. That's a good one.
Yeah. They're destroying access to care. They are destroying access to care, and nobody understands. I don't think there's a comprehensive knowledge of how much control they have in the patient's actual care. And that would be number one, but that would be a dream of mine too.
I know, a dream of mine too. And I know a dream of Dr. Maddie Feldman's because she's so anti-PBM. Do you think it's possible to change the Medicare system?
I think it's possible, but it takes everybody working together. And I think there has to be a real listening and understanding to actual patients and their stories and what they've been through and the hurdles that they've faced trying to get care. As physician practice managers, we can go down there all we want. They're like, oh, well, yeah, you get paid. Yeah, you're paid for what you do. They don't understand how little, but it's the actual patient that it affects, and until it happens to them or somebody in their family, I think it's not an issue. It's not a priority, I should say, for most. I mean, we do have some great lawmakers too.
So, bottom line, is there anybody who should choose an MA plan?
Honestly, I'm somebody who you never know what the future holds. I would say no, but if you're completely healthy and you don't expect to ever have any issues where you need any type of medication or to see any specialist, maybe it's the right plan for you. But the 90% of the population, I think regular Medicare, traditional Medicare is the way to go. It's tried and true. You know what to expect. You don't have to fight to get care as much as you would with, these plans that are managed by a commercial payer that, the CEOs are making billions.
Oh, yes, they are.
The B.
What about somebody who is on Medicaid? So if they qualify for Medicare, Medicaid, should they stick with Medicare, Medicaid, or should they pick an MA plan?
I stick with Medicare, Medicaid. You're covered. I mean, there's no reason to go outside of that because you're going to have copays. You're going to have, extra expenses if you choose a commercial plan. You're essentially going from something that's a sure thing, 100% coverage, to something that does not have 100% coverage. And I say stick with traditional Medicare.
And then and I don't know this answer, hopefully you do, if somebody has Medicare, Medicaid, and is prescribed a medication, is the medication going to be covered?
Usually I don't work a lot on the pharmacy benefit side, but I know with a lot of our biologic medications, and anyway, there's a cap that they pay, $3 for a medication. But yeah, 9 times out of 10, I have not seen it not covered.
Okay. So are you ready for a lightning round, Jaime Fiore?
Sure.
Oh, good.
Put me in the hot seat.
I know this is your hot seat, but this is gonna be easy. This is gonna be great. So, what is the first insurance term you learned that made everything click for you?
I think coordination of benefits and what that means.
Okay. one myth about Medicare that you correct most often.
That you're 100% covered all the time.
So what do you think is the biggest generational gap you see in how patients navigate insurance?
I think that our older generation, they expect it to be covered, whereas we're so used to, like, I want to put myself in the younger generation. The younger folks, they tend to expect to pay something because they're used to it coming out of their paycheck, their premiums. So I think there's a difference in generational there.
So what do you think Zoomer patients do better? These are not Zoomer patients. I'm going to say Zoomer advocates do better. They're 28 and under than boomers do when it comes to advocacy.
I think they Google a lot more and use ChatGPT and they take advantage of the technology.
Paper forms or portals, what slows down care more?
Oh, I honestly think I'm going to say paper forms in my office because there's a lot of back and forth and they never get it.
So prior auth in one word.
Administrative burden. That's 2 words, but burden.
We'll hyphenate it.
Yeah, burden.
The moment you knew you had to be an advocate, not just an administrator.
I think it's going back to that patient with Wagoners that needed care and couldn't get it.
What is the one question every patient should ask a broker before picking a plan?
Are they paying you to lead me to this plan?
That's great. Are they paying you?
Are they paying you and how much? And if I stay enrolled, are you getting a check every month?
What is the single insurance tactic that you'd overhaul right now?
Oh, that's a tough one. Single. I think that the formulary thing, changing formulary.
Midyear. Yeah. So I'm going to give you 30 seconds because I want to give you, I want you to speak to a patient and give them a pep talk on how to push back on a denial. So what is your 30-second pitch as a patient to push back on a denial?
I'm the patient or I'm counseling the patient?
Yeah, counsel the patient.
Okay. So Mrs. Jones, I see that they have denied your biologic treatment. You've been on it for a long time and it's worked for you. We've been through many medications before we got to this point. Our office has done everything we can do. You're the one paying your insurance premium. It's time for you to stand along. We'll stand with you, but it's time for you to call your insurance company and fight for your medication because we can't do anything. They won't listen to us. We're not the ones paying the premium. And I think the patient advocacy thing is huge.
Yes. Huge. I love that one. So I am going to end this podcast the same way I end every single podcast, Jamie, and I know you listen, so you know, and I've asked you a lot about changes, but looking at the entire American healthcare system, what is one change that you think or would like to create now?
Let the physicians be physicians. Cut out the middleman. The administrative burden has gotten in the way of actual patient health care. And doctors just cannot be physicians anymore. They have to do it all, and it's not fair. It's not fair to the patient. It's not fair to the physician who just wants to care for the patient.
Jaime Fiore, thank you for being on Working Healthcare.
Thank you for having me.
If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going. Got a question, an episode idea, or someone you think we should feature? Send a note to meredithhirsh.com. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare because you can't fix what you don't understand.
You ready? You got me running, got me running. Shake it, shake it, shake it.